Well, studies have shown that patients with fibromyalgia alone that receive steroids get worse because of the effect the steroids have in their sleep. So if someone tells me they're 100% better after steroids for poison ivy, poison oak, asthma, then I know in addition to fibromyalgia, they have something else that needs to be treated. And it's likely that it is inflammation. And again, if you don't treat that, people won't do nearly so well. So you really think also, besides treating fibromyalgia, how else can I improve the lives of people I see or providers that you're seeing? And I think that's really important. Make sure your history is good. If you're having cognitive problems, bring someone else with you the first time just to help out. History is extremely important because if you rely on lab only, we're going to miss many, many conditions, including thyroid conditions in patients with fibromyalgia. And if you treat these conditions, everyone will feel significantly better. So if you look at rate of mood disorders, and on the left is mood disorders, and you'll see that patients with fibromyalgia are no more likely to have a mood disorder than patients with rheumatoid arthritis, and far less likely than patients with chronic back pain. If you look at anxiety, the same patients with chronic back pain and fibromyalgia patients are about the same. So you're really seeing these changes in patients with chronic pain. The frustration of going through your lives every day and having pain and or fatigue or cognitive problems. But to date, there's been no evidence that this is a psychiatric condition. And if someone tells you it's a psychiatric condition, find someone else. Differential diagnosis, there's much more than this really, but people that see you know that you could have lupus despite the fact you have fibromyalgia. You could have ankylosing spondylitis. And the symptoms of ankylosing spondylitis are so similar to patients with fibromyalgia that one of my colleagues treats most patients with fibromyalgia with a trial of a medication to treat spondylitis. And I really can't fault him for that. And some of them get better, the majority don't, but he's picked up a number of patients who he's treating successfully. Multiple sclerosis, fibromyalgia is described with that. Thyroid. Many patients with fibromyalgia have normal thyroid tests. That doesn't mean you don't have thyroid problems. And I'd recommend going to a really good endocrinologist. I think the top one in my experience for looking at hidden or occult thyroid disease in patients with fibromyalgia is Robert Murray. He's really excellent in listening to your symptoms, doing further studies, and then determining whether trial of thyroid would work. So I think that's really important. Look for that, get it treated. Inflammatory bowel disease, not the same as irritable bowel syndrome. These are patients that are often very, very ill and they have blood in their stool and fevers. They can be treated. And patients sometimes are misdiagnosed as having irritable bowel syndrome when they're inflammatory. Any kind of muscle problem can be confused with fibromyalgia, that's the myopathy. Polymyalgia rheumatica, an illness that occurs in people over the age of 50 with extreme stiffness and inflammation and virtually cured by prednisone, a low dose. So that's in the consideration of someone, you think they have a lot of inflammation because they have an hour of stiffness, 2 hours of stiffness in the morning, you try them on low dose prednisone, and miraculously they're better within a couple of weeks.
What is low dose?
Well, with polymyalgia rheumatica, 5 to 15 milligrams. Often we'll try 7.5 milligrams for 2 weeks. If you take prednisone for only 2 weeks, you can cold turkey it. If you take it longer, you really have to slowly get off it. Hepatitis C, again, anyone with fibromyalgia should be tested for hepatitis C. And then Sjogren's syndrome because of the dryness. Sjogren's presents with musculoskeletal complaints and severe dryness. And many patients with fibromyalgia have severe dryness, either because that's part of fibromyalgia or because of medications they're on. So that really should be considered always. Well, we do think this is a central pain mechanism. We used to feel it was muscle. And if you do biopsies of muscles, you'll get nonspecific changes, type 2 atrophy, and that's felt to be because of disuse, because of the pain. But there is emerging evidence that this is a central pain mechanism, and the three components of a central pain mechanism are allodynia, and that is pain on soft touch. You're aware of that. Sometimes it's difficult to even sleep because of the bed covers, difficult for people to touch you, and it's called allodynia. And then hyperalgesia is a second component of a central pain mechanism. Hyperalgesia is areas in which they're painful for all of us, but patients with fibromyalgia have much greater legitimate pain when those areas are touched, such as the outside of the elbow. And then the third component of a central pain mechanism is called widening of the fields, and that is how a local injury can present with diffuse and widespread pain. Fibromyalgia satisfies all of this criteria. So it appears really to be a central pain mechanism and should be treated as a central pain mechanism. There's evidence from functional MRI scans. Some of them were done by John Russell, who many of you may know, who's chief of rheumatology, University of Texas, San Antonio. In these studies, patients were subjected to a functional MRI scan while the thumbnail was being pressed. And if you can see, patients with fibromyalgia, the red triangle, had severe pain with minimal pressure on their thumbnail, and it took almost triple the pressure on a normal control to have that kind of pain. But the other important thing was that pain was reflected in a scan. No one can say any of this is subjective anymore. There's a lot of data showing it's objective. What Russell did was he did tender point exams in patient and saw the functional MRI scan go wild. So when someone says it's just self-reported, it's absolutely not self-reported. There's a lot of objective evidence for this now. It's published, it's available. If your provider says it's not objective, have him or her just do a literature search on objective findings in fibromyalgia. I think they'll be surprised, but also they may be able to help you more. So recent data suggests that alterations of the central nervous system may contribute to the chronic widespread pain. Functional MRI scan confirmed that. There is objective evidence for pain, for central pain in these patients. And then one of the ways to treat this certainly is to try to reduce these hyperexcitatory neurotransmitters. And we've been successful in doing that. Biochemical markers, if someone were to do a spinal tap in you, they would find abnormalities. Again, another objective finding. Substance P is greatly elevated. Substance P is associated with pain. Serotonin is reduced, but it no longer figures into fibromyalgia. Initially, we really thought that was the key. But if you use selective serotonin reuptake inhibitors such as Prozac, they really don't change the course of the disease like some of the other antidepressants. So we think serotonin is not one of the chemicals we're really concerned about, but there are many others: nerve growth factor, growth hormone, dynorphin A, and then CGRP. Pharmacological therapies include sleep remedies, antidepressants. I've been warned this hook is going to take me off the stage if I go over, so if I speed up occasionally, you'll know that I've been watching for this hook. Analgesics, muscle relaxants, growth hormone, and I really want to go through some of these: seizure medications, dopamine agonists, substance P inhibitors or modulators, guaifenesin, vitamin D. Sleep remedies, from over-the-counter to antihistamines, melatonin. You know, there is a new brand name sleep remedy that works in melatonin receptors. And then benzos. The trouble with most of these is they actually make you feel worse when you wake up. They're either nonspecific or they interfere with deep sleep, not REM sleep, deep sleep, stage 3 and 4.